Subcommittee will come to order, and good afternoon to everyone. I have called this emergency hearing today during recess to address a grave and serious health threat which has in recent weeks gripped the mass media and heightened public fears of an epidemic, the Ebola virus. What we hope to gain from today's hearing is a realistic understanding of what we're up against while avoiding sensationalism. Ebola is a severe, often fatal disease that first emerged or was discovered in 1976 and has killed 90% of its victims in some past outbreaks. Since March of this year, there have been more than 1,700 cases of Ebola, including more than 900 fatalities in Guinea, Liberia, Sierra Leone, and Nigeria. This time, the average fatality rate in this outbreak is estimated at 55%, ranging from 74% in Guinea to 42% in Sierra Leone. The disparity in mortality rates are partially linked to the capacity of governments to treat and contain the disease and perhaps per capita health spending by affected governments. There is also concern that given modern air travel and the latency time of the disease, the virus will jump borders and threaten lives elsewhere in Africa and even here in the United States. In my own state of New Jersey, at Centra State Hospital in Freehold, just a few hundred yards from my district office, precautions were taken. A person who had traveled from West Africa began manifesting symptoms, including a high fever. He was put in isolation. Thankfully, it was not Ebola, and the patient has been released. New Jersey Health Commissioner Mary O'Dowd reiterated to me yesterday that New Jersey hospitals have infection control programs in which they train and are ready to deal with potentially infectious patients that come through their doors. She also told me that physicians and hospital workers follow very specific protocols prescribed by the CDC on how to protect themselves as well as other patients and how to observe a patient if they have any concerns, which includes protocols like managing a patient in isolation so that they are not around others who are not appropriately protected. The Commissioner also underscored that the federal government has U.S. quarantine stations throughout the country to limit introduction of any disease that might come into the United States at ports of entry like New Jersey's, Newark Liberty International Airport. I also hope our distinguished witnesses today will confirm whether sufficient resources are available and are being properly deployed to assist victims and contain the Ebola disease. Are there gaps in law and policy that Congress needs to address? To the government witnesses especially, my pledge to you is that if legislation is needed, I will work, and I know I'll be joined by colleagues on both sides of the aisle, will work with you to write those new policies. As you know, key symptoms of Ebola include fever, weakness, head, joint, muscle, throat, and stomach ache, and then vomiting and diarrhea, rashes and bleeding. These symptoms are also seen in other diseases besides Ebola, which make an accurate diagnosis early on uncertain. Earlier today, I had a full briefing, a lengthy briefing, with the Deputy Chief of Staff of the President of Guinea, President Condé, Ibrahim Khalil Kaba, who said that the virus has masked many other diseases, including Lassa fever. So many of the doctors, especially those who have never seen Ebola in this part of the world before, it's been in other parts of Africa, but not in West Africa, just simply didn't think this would be Ebola. Many of them have died. Ebola punches holes in blood vessels by breaking down the vessel walls, causing massive bleeding and shock. The virus spreads quickly before most people's bodies can fight the infection, effectively breaking down the development of antibodies. As a result, there is massive bleeding within 7 to 10 days after infection that too often results in the death of the affected person. Fruit bats are suspected of being a primary transmitter of Ebola to humans in West Africa. The virus is transmitted to humans through close contact with the blood, secretions, organs, or other bodily fluids of infected animals. Some health workers, such as the heroic American missionary aid workers, Dr. Kent Brantley and nursing assistant Nancy Wright-Bowl, had contracted the disease despite taking every precaution while helping Ebola patients. Both of them are now being treated at Emory Hospital in Atlanta, Georgia, in an isolation unit after being flown to the U.S. in a specially equipped air ambulance. While there is no known cure for Ebola, both Dr. Brantley and Ms. Wrightball have been given doses of an experimental antiviral drug cocktail called ZMapp, developed by a San Diego company called MAP Biopharmaceutical. They are reportedly both feeling stronger after receiving the drug, but it is considered too early to tell whether the drug itself caused improvement in their conditions. MAP Biopharmaceutical has been working with the National Institutes of Health and the Defense Threat Reduction Agency, an arm of the military responsible for counting weapons of mass destruction, to develop an Ebola treatment for several years. The drug, which attaches to the virus cells, much like antibodies their compromised immune systems would have produced, has never been tested on humans before Dr. Brantley and Ms. Wrightball, who gave their consent to be the first human trials. There will be hope, great hope, if ZMapp works and the two Americans who bravely agreed to test it and it has a positive effect. Still, it won't mean that it will be produced in great quantities quickly and sent to affected people in West Africa. It is still an experimental drug. Those who use it might be given complete information on its use, again, but that still is something that our experts, I hope, will address. There's also promising research being done by Tecmera Pharmaceuticals. They have come up with a drug, a process, and one of the comments that has been made that it's never been tested on humans, that it has been 100% provided 100% protection from an otherwise lethal dose of Zaire Ebola virus, but again, not in humans. It's been done in others, non-human. Unfortunately, there are other issues that impact the ability of the international community to assist the affected governments in meeting this grave health challenge. Some of the leading doctors in their countries have died treating Ebola victims. The non-governmental and medical personnel who are there say they are besieged, not only because they are among the only medical personnel treating this exponentially spreading disease, but also because they are under suspicion by some people in these countries who are familiar with this disease and unfamiliar, and they fear that doctors who treat the disease may have brought it with them. Of course, it's not true, but again, myths do abound. The current West African outbreak, as we all know, and as Dr. Frieden has said, is unprecedented. Many people are not cooperating with efforts to contain the disease. There's an information gap. Despite the efforts through cell phones and radio to get the message out, of course, there is still a learning curve. As we consider what to do to meet this health challenge, I do suggest we reconsider the funding levels for pandemic preparedness. And this message is to us in Congress and to the executive branch. In the restricted budget environment in which our government operates, funding to meet these pandemics has fallen from $201 million in fiscal year 2010 to an estimated $72 million in 2014. The proposed budget for fiscal year 2015 is $50 million, and we mustn't shortchange vital efforts to save the lives of people in these developing countries. Dr. Tom Frieden, one of today's expert witnesses, has tried to assure the American public that our government is doing what we can do to address the Ebola crisis. He has announced the dispatch of at least 50, perhaps more, public health experts to the region within the next 30 days. USAID, WHO, the World Bank, the British Development Agency, African Development Bank, and many others have also are joining in trying to meet this crisis. To those who say we have no plan, I would say that planning is definitely underway, and it's being done so very aggressively. Still, there is much more that needs to be done. I would just say, finally, I've introduced legislation that's known as the End Neglected Tropical Disease Act, which establishes the policy of the U.S. to support a broad range of implementation and research and development activities to achieve cost-effective and sustainable treatment, control, and where possible, elimination of neglected tropical diseases. Ebola is not on WHO's list of the top 17 neglected tropical diseases, but it does fit the definition of an infection caused by pathogens that disproportionately impact individuals living in extreme poverty, especially in developing countries. Ebola had been thought to be limited to isolated areas where it could be contained. We now know that's no longer true. We need to take seriously the effort to devise more effective means of addressing this and all neglected tropical diseases. I now yield to my good friend and colleague, the ranking member, Ms. Bass.
Mr. Chairman, thank you for your leadership and for calling today's emergency hearing to give us an opportunity to learn about and work to address the current Ebola outbreak in West Africa. I look forward to hearing directly from our witnesses today on the work their agencies and organizations are doing to combat the deadly outbreak and how they have coordinated with the governments of impacted countries. I appreciate their efforts and outreach to keep Congress informed on this ever-evolving and devastating situation. This outbreak comes as nearly 50 African heads of state join us here in Washington, D.C. this week as part of the first in history U.S.-Africa Leaders Summit. I've been honored to join my African and American colleagues as we have worked together to reach the full capacity and promise of the African continent. We've had several productive sessions that further cemented the relationship between the U.S. and African nations and highlighted areas of opportunity for us to continue to work together. Despite the meaningful dialogue and collaboration that occurred this week, there is still work to be done. The development of healthcare capacity and global health security is just one area of collaboration for the U.S. and African nations. I do have to say that I was a little dismayed that with all of the activities that happened this week around the summit, obviously the crisis we're dealing with today is very, very important. But when it came to coverage on Africa, the coverage centered pretty much solely around Ebola. I want to commend the steps being taken by the governments of Liberia, Sierra Leone, Guinea, Nigeria, and the U.S., and the great work of the many health professionals from throughout the world who are doing everything they can to help people who have contracted this awful disease. With over 1,700 suspected and confirmed cases and over 900 deaths since March, the current Ebola outbreak we know is the longest-lasting, widespread, and deadliest outbreak ever recorded. This is also the first Ebola outbreak ever in West Africa and the first outbreak to be spreading in both rural areas and capital cities. The unique nature of this outbreak has made combating the disease particularly difficult. West Africa has not faced this disease before, and communities, government, and health professionals in the nations do not have the expertise and capacity to address the scale, spread, and proper treatment of the Ebola outbreak. This lack of logistical expertise, healthcare workforce, and supplies has hindered the ability of governments to quickly identify, track, and isolate new cases and properly care for those infected. Officials have also had to fight against fear of the disease and cultural unfamiliarity with proper treatment, which have really contributed to the spread and kept people from seeking care. Yesterday, I had the privilege to speak to President Ellen Johnson Sirleaf on the impact of the outbreak on her country and the work they've done to fight the disease. I asked her what more we could be doing, and one of the things she talked about was the need for logistical support, the need for training of their healthcare workforce so that they would know how to prevent the disease. And I'm sure Dr. Frieden, and I spoke with him yesterday also, is going to say that we do know how to prevent the spread of the disease, but that's where our efforts need to be directed. The other thing that the President said was that the problem, of course, with the outbreak is all of the resources are centered toward the outbreak, and then just routine medical care has really suffered because there hasn't been the workforce to be able to handle both. So President Sirleaf called for increased international assistance to provide food and water to impacted communities. She said that the communities that were most heavily impacted were quarantined, and that there needed to be food and water brought into the areas, especially in situations like this. You have a concern that civil unrest could be an outbreak, especially in areas that are quarantined that feel that they do not have access. And so she felt that that was one of the ways that the United States could help the best. It is obviously in our interest and in the world's interest to assist in the crisis and to continue to support nations as they fight this outbreak and work to develop and strengthen their healthcare systems. Healthcare is a human right, and we must ensure that countries have the ability to address this outbreak, and we're able to move forward and prevent future health epidemics from occurring. Both the chairman and I have introduced legislation to respond to this crisis, and I look forward to your testimonies, and I'm interested in hearing from all of you about what more Congress can do to assist your efforts to combat the disease outbreaks and support international efforts to improve healthcare systems around the world. Thank you.
Thank you very much, Ms. Bass. I would just like to recognize in the audience Zainab Bangura, who is the Special Representative to the Secretary General of the UN on Sexual Violence in Conflict. Thank you for joining us today. Oh. And I would like to now yield to the distinguished chairman of the State Department, Commerce, and Justice Department Subcommittee of the Appropriations Committee, Congressman Frank Wolf, who has had a 34-year career of tremendous support for the weakest and the most vulnerable. And matter of fact, the genesis of this hearing was a conversation with Ken Isaacs from Samaritan Purse last week. We were planning on a hearing on the Ebola virus for September. And the sense of urgency, and Congressman Wolf, Chairman Wolf was the one who set up that conference call. The sense of urgency was so great that the thought was that it's better now, and we could have more hearings in the future and more action plans and the like. So I want to thank the chairman for his tireless efforts on behalf of the weak and vulnerable. Chairman Wolf.
Thank you, Mr. Smith. I want to thank my good friend, Chairman Chris Smith, for pulling together today's hearings on such a short notice amid the escalating outbreak of Ebola across West Africa countries, including Liberia, Sierra Leone, Guinea, and now Nigeria. I also appreciate him inviting me to join today's hearing. Although not a member of the Foreign Affairs Committee, I do serve on the State and Foreign Appropriations Subcommittee, which funds the State Department and foreign aid programs. I would also say to the witnesses, too, if you need extra money, you ought to ask for reprogramming. You oughtn't to be waiting till September and October and November and December. You should ask for it immediately, and I am confident that the appropriate committees up here will allow you. But if in doubt, there should be the request for the reprogramming. The current Ebola epidemic has claimed over 900 people since it was first detected earlier this year and has proven to be the world's worst outbreak of the virus ever recorded. It now appears that this alarming contagious disease could be on the verge of spreading. On July 28th, I received a call from Ken Isaac with Samaritan's Purse, one of the witnesses here today. Let me say, Samaritan's Purse and Doctors Without Borders have done more to help the poor and the suffering in many places than almost any other groups around us. So I want to commend Samaritan's Purse, and I also want to commend Doctors Without Borders. Wherever you will go in Africa, they will be there when other groups have long, long gone. Samaritan's Purse was on the front line working to curtail the Ebola outbreak. The outlook, absent immediate action from the United States, was bleak. It appears that both the international health organizations and the Obama administration underestimated the magnitude and the scope of the epidemic. Despite well-intentioned efforts by local and international aid workers, doctors and nurses working on the ground, it seems the international community and the U.S. had been noticeably absent in helping these West African countries to get out in front of the spread of this epidemic. For the first part of the epidemic, the international community simply let 3 of the most impoverished countries in the world deal with the Ebola threat essentially on their own. It should be no surprise that the health systems in Liberia, Guinea, and Sierra Leone do not have the resources or the capacity to deal with this epidemic on their own. Despite early warnings from those NGOs working on the ground, there was little action taken to get out in front of this problem, and now we are seeing the consequences. Nothing can bring back the lives that were lost, and even the money and personnel deployed to help may not be enough to contain the epidemic. I spent much of last Monday, on the 28th of July, on the phone with the White House, State Department, CDC, HHS, trying to understand just what, if anything, the U.S. was doing both to help contain the outbreak in Africa and prevent the spread of Ebola to the U.S. I was concerned that no one could tell me who was in charge within the administration on this issue. No one could explain what actions would be taken to ensure the U.S. was prepared to respond. Although more progress has been made over the last week since these conversations, it's clear that the government is still trying to catch up. This grave situation requires immediate, coordinated efforts across agencies and countries. France, Great Britain, many of the countries in Europe who are very experienced in Africa should also be brought in. It also has come to my attention there needs to be an immediate response to the existing deficiencies in CDC planning, procedures, and protocols in response to the Ebola threat. As Mr. Isaacs will share today, and I've read his testimony, when its 2 healthcare workers were confirmed with Ebola, Samaritan's Purse struggled to get guidance on protocols for dealing with returning healthcare workers from the region. It soon became apparent that there were significant gaps in existing procedures for dealing with this. The CDC had no available registry of medical facilities capable of treating Ebola patients in the United States. There are no quarantines or travel restrictions in place. And there was concern that these gaps in the protocols, and how do you deal with them? I appreciate very much, and I want to thank Dr. Frieden. He took the call, he was getting on an airplane, and I want to publicly thank you, Doctor. I am very appreciative who is here today, and hope he will talk about any deficiencies and how they can be addressed by the government and also by the Congress. In closing, I want to thank again Chairman Smith for calling this hearing during the August recess. I also want to recognize the men and women of the CDC and other international response groups who are on the ground and soon will be on the ground in Africa, as well as the doctors and nurses helping the 2 patients in Atlanta. I want to thank them because this is very dangerous, what they will be doing and what people who we do not know their names will be doing. I think we should just tell them that we are appreciative. I also want to thank the State Department and the Department of Defense for their invaluable assistance as this thing has taken place. This is important and serious work, and I know the American people, if they knew what they were doing and had been done, would appreciate their tireless efforts. This should be a very top priority of the White House, the political leadership of the nation. We know the career people, what they're going to do, but of the White House, because the American people deserve to know what their government is doing to prevent the spread of this epidemic and keep the country safe. And with that, Mr. Chairman, again, thank you.
Chairman Wolf, thank you so very much. I'd like to now introduce our first panel of 2 panels, beginning first with Dr. Tom Frieden, who has been director of the Centers for Disease Control and Prevention, CDC, since June of 2009, and has worked to control infectious and chronic diseases in the United States and globally. He led New York City's program that controlled tuberculosis and reduced multi-drug resistance cases by 80%, and worked in India for 5 years, helping to build a tuberculosis control program that has saved nearly 3 million lives. As the commissioner of New York City's health department, Dr. Frieden led programs that reduce illness and death and increase life expectancy substantially. He is a recipient of numerous awards and honors and has published more than 200 scientific articles and has previously testified before this committee on drug-resistant diseases, as well as other very important health topics. Thank you, Doctor, for being here. I then would like to introduce Dr. Ariel Pablos-Méndez, who is the Assistant Administrator for Global Health at USAID, a position he assumed in August of 2011. Dr. Pablos-Méndez joined USAID's leadership team with a vision to shape the Bureau for Global Health's programmatic efforts to accomplish scalable, sustainable, and measurable impact on the lives of people living in developing countries. Prior to joining USAID, he worked on global health strategy and transformation of health systems in Africa and Asia. He also served as Director of Knowledge Management at the World Health Organization. Dr. Pablos-Méndez is a board-certified internist, and until recently was practicing as a professor of clinical medicine and epidemiology at Columbia University. And then we will hear from Ambassador Bisa Williams, a career member of the Senior Foreign Service with the rank of Minister Consular and currently Deputy Assistant Secretary in the Bureau of African Affairs at the U.S. Department of State. Ambassador Bisa has served as ambassador to the Republic of Niger from 2010 to 2013. She has also served in U.S. embassies in Mauritius, France, Panama, and Guinea. Ambassador Williams' postings have also included Director for International Organizations in the National Security Council at the White House and advisor at the U.S. mission to the United Nations in New York. And without objection, fuller resumes, and they are very deep and very distinguished, of all three of our witnesses will be made a part of the record. Dr. Frieden, the floor is yours.
Thank you so much, Chairman Smith, Ranking Member Bass, Congressman Wolf, for your interest in global health, for your interest in Ebola, and for calling this hearing at this really critical and pivotal time. I think first let's remember the lives and the faces of the men, women, and children who are affected by the Ebola outbreaks in the 4 countries currently affected, especially the healthcare workers, who account for a substantial proportion of cases. Those are the people who we must focus on. Those are the people who we must support. And it is in Africa that we can stop this outbreak and protect not only these countries, but ourselves as well. We focus on what works. And I'm incredibly proud of the staff of the Centers for Disease Control and Prevention. And I think every American who would know the expertise, dedication of the disease detectives, laboratory experts, disease intervention specialists who have been on the ground in the past few weeks and months and who are now surging for our response would be proud to know what we're doing there. I want to start with the bottom line. 3 basic facts. First, we can stop Ebola. We know how to do it. It will be a long and hard fight, and the situation in Lagos, Nigeria is particularly concerning. But we can stop Ebola. Second, we have to stop it at the source in Africa. That's the only way to get control. And third, that we have to stop it at the source through tried and true means, the core public health interventions that work and that I'll go through in a few moments. By way of background, Ebola is one of several viral hemorrhagic fevers. There are others, but Ebola is the most feared in part because it had a movie made about it. There are others that are just as deadly. The first Ebola virus was identified in 1976 in what is now the Democratic Republic of Congo, and there have been sporadic outbreaks since. The natural reservoir is not known, but is believed to possibly be bats, which then pass it to primates and other forest-living mammals, and humans may come in contact with them by eating bushmeat or contact with bats. That's a theory. There is increasing evidence for it, but we're not certain of it. What we are certain of is that when Ebola gets into human populations, it spreads by 2 routes. First, to people who are giving care to individuals who are sick with Ebola. Ebola does not spread from people who have been infected but are not yet sick. So it's only the sick people who transmit it. And second, it's transmitted only by close contact with exchange of body fluid. So a healthcare worker or a family caregiver who comes into contact with a patient who's very ill, maybe bleeding or have other body fluids that get onto that individual, that's how Ebola spreads. And in the outbreaks in Africa, there have been 2 main drivers: healthcare settings and other caregiving settings, including the family, and burial practices, where there may be practices that involve contact with a recently deceased person. Those are the drivers of Ebola in Africa. Again, Ebola only spreads from people who are sick and only spreads through contact with infectious body fluids. It does not spread through casual contact. It is not an airborne disease as it spreads in nature. It doesn't spread through water or food. And the incubation period is usually between 8 and 10 days from exposure to onset of illness. It can be possibly as short as 2 days and possibly as long as 21 days. But in that period, it's essential that any contact be very closely monitored to determine if they've developed the symptoms of Ebola, and if they have, are followed up. We do know how to stop Ebola. Meticulous case finding, isolation, and contact tracing and management. We, with our partners, have been able to stop every Ebola outbreak to date, and I'm confident that if we do what works, we will stop this one also. But it won't be quick, and it won't be easy. It requires meticulous attention to detail, because if you leave behind even a single burning ember, it's like a forest fire. It flares back up. One patient not isolated, one patient not diagnosed, one healthcare worker not protected, one contact not traced. Each of those lapses can result in another chain of transmission and another flare of the outbreak. To control the outbreak, we have to work effectively. And the challenge really isn't the strategy. The challenge is the implementation of that strategy. Mr. Chairman, we've provided to the committee this basic information on how Ebola can be controlled. And if you would permit me, I'll just go very quickly through this because I think it's important to get the fundamentals out there. First, to find patients and diagnose them. That means fever or other symptoms. The only way to diagnose Ebola is with a laboratory test. That's generally done by a blood test in Africa, and we, working with partners from the Department of Defense, from the Pasteur Institute of France, from other countries, and the countries where the disease is present, are scaling up the ability to diagnose patients. So the first, that diagnosis is suspect it with fever, test with blood, get it tested in the lab. That's a critical first step. The second step is to respond to those individual cases. We do that by putting patients in isolation, by interviewing them and eliciting their contacts, and then by following each and every contact every day for 21 days. And if a contact develops fever, begin that process all over again. Interview them, isolate them, find out who their contacts are. It's laborious, it's hard, it requires local knowledge and local action, but it's how Ebola is stopped. And third, prevent it. Prevent it through infection control in healthcare, safe burial practices, and reducing the consumption or unsafe consumption of bushmeat in contact with bats. The current outbreak is a crisis. It is unprecedented, and it's unprecedented in 5 different ways. First, it's the largest outbreak ever. In fact, at the current trend, within another few weeks, there will have been more cases in this outbreak than in all previous recognized outbreaks of Ebola put together. Second, it's multi-country. And one of the biggest challenges is that one of the epicenters is on the confluence of 3 different countries. And cases have moved between countries. One country gets control, and then patients come in from another country. So that tri-country area is a critical challenge. Third, this is the first outbreak in West Africa. This was a disease that was unknown, as far as we know, in that area before. And because of this, it's been a particular challenge, and the health systems in these countries are quite weak, and this also is a challenge. Fourth, many of the cases have been in urban areas, and there has been spread in urban areas, and this is something we have not seen to this extent before. From everything we know to date, this doesn't appear to be a change in the virus, but it is a new development in how and where the virus is spreading, and it makes control much more difficult. And fifth, it's the first time we're having to deal with it here in the United States. And that's not merely because of the 2 people who became ill caring for Ebola patients and were brought back to the U.S. by their organization. That's primarily because we are all connected. And inevitably, there will be travelers, American citizens and others, who go from these 3 countries or from Lagos, if it doesn't get it under control, and are here with symptoms. Those symptoms might be Ebola or something else. So we're having to deal with Ebola in the U.S. in a way that we've never had to deal with it before. The U.S. is working in a coordinated way to support partner governments and the World Health Organization. I have activated the CDC Emergency Operations Center at level 1 for this outbreak. This is our highest level of response. It doesn't mean that there's an increased risk to Americans, but it does mean that we are taking an extensive effort to do everything we can to stop the outbreaks. We can't do it alone. There are many partners throughout the U.S. government who we're working with, the World Health Organization, the World Bank, partner governments around the world, as well as, most importantly, people in country will be key to stopping the outbreak. We will send, as I have said, at least 50 staff to the region within the next week or 2, actually. We'll have reached that 50 number. But I think it's important to understand that the 50 in-country are supported at our home base in Atlanta by a much larger group. As of today, even before the full surge and activation, we have more than 200 staff working on this outbreak response, and we will increase that number substantially in the coming days and weeks. You'll hear more about the work we're doing with the U.S. Agency for International Development, where we're using an unprecedented model to work together in a collaborative way to rapidly identify and call in for reinforcements and assistance. When we finish this response, we're determined to not only stop the outbreak, but leave behind strong systems that will be better at finding the disease and other threats, at stopping it before it spreads, of preventing it in the first place. In fact, if those systems had been there in the first place, we wouldn't be here today. The outbreak would have been over already. We don't know how to treat Ebola, and we don't know how to vaccinate it. We don't have medications that cure it, but we do know how to care for patients with Ebola. You may have seen a lot of press coverage about experimental treatment, and the plain fact is that we don't know whether that treatment is helpful, harmful, or doesn't have any impact. And we're unlikely to know from the experience of 2 or a handful of patients whether it works. We do know that supportive care for patients with Ebola makes a big difference. Supportive care saves people's lives, giving them fluid, making sure they're not over or under their fluid balance, giving them supplemental oxygen if it's needed, treating other infections that occur, providing good quality health care. We're currently coordinating with NIH, FDA, the Department of Defense, and others to see whether there can be new treatments and whether these treatments can be effective and available. But there's a lot we don't know about that yet. It's important that we keep in mind that we do know, even without medicines that are specific to Ebola or a vaccine, we do know how to control it and we can stop it. I want to spend a moment on what we're doing to protect people in this country. First off, the single most important thing we can do is to stop the outbreaks, to stop it at the source. The second issue that we are working on is to help these countries do a better job screening people who are leaving their countries so that they'll screen out people who are ill or who may be incubating Ebola. And third, because we recognize that we are interconnected, we're working closely with state and local health departments and health providers throughout the United States so that they're aware that there could be people who come from these 3 countries who've been there in the last 3 weeks. If they come in with fever or other symptoms, they should think that it could be Ebola. Immediately isolate them in the hospital and get them tested at CDC. We've issued a Level 3 travel advisory against all non-essential travel to Guinea, Sierra Leone, and Liberia. We've issued a Level 2 travel advisory about enhanced precautions on Nigeria, and we will reassess the Nigerian situation daily or more frequently as needed. There is strict infection control possible in hospitals in the U.S., and there has been some misconception about this. Ebola is not as highly infectious as something like influenza or the common cold. What's so concerning about Ebola is that the stakes are so high, that a single lapse in standard infection control could be fatal. That's why the key is to identify rapidly and strictly follow infection control guidance. It is certainly possible that we could have ill people in the U.S. who develop Ebola while here after having been exposed elsewhere. It is possible that they could spread it to close family members or to healthcare workers if their infection is not rapidly identified. But we're confident that there will not be a large Ebola outbreak in the U.S. We're confident that we have the facilities here to isolate patients, not only at the highly advanced ones like the one at Emory, but really at virtually every major hospital in the U.S. What's needed is not fancy equipment. What's needed is standard infection control rigorously applied. We've released guidance for doctors and other healthcare providers in the U.S. on identifying, diagnosing, and treating patients, and guidance for airline flight crews, cleaning personnel, and cargo personnel. Fundamentally, to end here, we have 3 roads before us. We can do nothing and let the outbreak rage, and I don't think anyone wants to do that. We can focus on stopping these outbreaks, and that's something that we will certainly do. Or we can focus not only on stopping these outbreaks, but also on putting in place the laboratories, the disease detectives, the emergency response systems that will find, stop, and prevent future outbreaks of Ebola and other threats. We do face in this country a perfect storm of vulnerability with emerging infections like Ebola, resistant infections like the ones we discussed in our last hearing, intentionally created infections which remain a real threat. But we have unique opportunities to confront them with stronger technology, more political commitment, and success stories on real progress from around the world. Earlier this year, the U.S. joined with the World Health Organization and more than 24 other countries to launch a global health security agenda. That global health security agenda is exactly what we need to make progress not only in stopping Ebola, but in preventing the next outbreak. And the second document that we provided for you provides a summary of what the mapping is between what we launched back in February before this outbreak was known or reported to have started, and what's needed to stop the Ebola outbreak, and they're closely aligned. The President's budget includes a request of $45 million to CDC to accelerate progress in the detection, prevention, and response. A former Secretary of State for Africa said to me, Undersecretary of State for Africa, said to me, citing his decades of work, that CDC is the 911 for the world. And though I was happy to hear that, I realized that really what we want to make sure is that every country, or at least every region, has its own public health 911. That'll be good for them, it'll be good for us in terms of safety, it will improve economic and social stability. And expanding that type of work, strengthening global health security, will allow us to not only stop this outbreak, but also prevent future outbreaks and stop them faster if they do occur. Thank you so much for your interest in this topic.
Dr. Frieden, thank you very much for that very comprehensive and incisive testimony. I'd like to now yield to Dr. Pablos-Méndez.
Thank you very much, Chairman Smith, Ranking Member Bass, Chairman Wolf. Thank you for this opportunity, very timely, to allow us, the U.S. Agency for International Development, to present to you an update on where we are with the work on this tragic and alarming outbreak of Ebola in Western Africa. You have been a long-standing supporter of this area, and Member Bass quite so for Africa, and so we couldn't have better champions in this emergency. The epidemic of Ebola in Western Africa is historic because both the magnitude is unprecedented as well as because it has never really occurred in this region, or as we heard from Tom, spreading to cities and the risk of spread beyond the region. I am, like many of you, saddened to see the devastation of the loss of lives caused by this outbreak, but also the broader social economic disruption that this is inflicting in the region, where it's really a set of fledgling democracies in Western Africa. The good news, as we have heard, is we know how to deal with Ebola. Since 1976, there have been about 30 or so outbreaks in Central Africa. And each of those, of course, have been contained. And the systems don't have to be perfect. The basics have to be in place. Systems have to be familiar. Uganda has a track record that is worth noting. In the year 2000, they had about 425 cases during that outbreak. The support that we provided allowed that outbreak to be contained. Subsequent outbreaks in 2008 only saw 149 cases, two-thirds reduction. And in the last outbreak in the region, 2011-2012, the number was only 32. So systems can learn, can prepare, can deal with this outbreak. We have done it many times, and as Tom has said, we know exactly what to do. USAID, with the support that you gave us all along, provide routine funding to both CDC, the World Health Organization in Geneva and in Africa, to have preparedness, planning, and response. And indeed, that has been part of the machinery that has been put in place here. We support about 22 laboratories in 18 countries in Africa and Asia, where almost 500 new viruses have been detected just in the last 5 years. So there's a lot of activity going all the time. This particular virus of Ebola is, again, familiar to us, and as far as we can tell from a biological genetic point of view, it is really the same virus. It's not that it's a new mutant virus that has taken on new powers. It is the same virus we're familiar with, but it's entered a new region, and it's entered, perhaps as we speculate, because bats that had been tested positive in Central Africa are now also tested positive in Western Africa. This ecological dimension of the work that we do has to be kept in mind. And because of the novelty of this, neither the immune systems of the people in Western Africa nor their health systems were experienced in dealing with the outbreak, which has contributed to the dimensions of this. USAID has also targeted in this year the response in Western Africa. We started earlier this year supporting with a $2.1 million investments through WHO, through UNICEF, and it's being reinforced now with $12.4 million to support CDC, the WHO, and the like. Indeed, it's important to note to Chairman Wolf's comments that the outbreak in Sierra Leone and in Liberia had it started really, probably started as, in retrospect, we now, with verbal autopsies, can see that is earlier on, but the cases were identified in late March, and for a couple of weeks we had this outbreak that then went down, so that in the spring the initial outbreaks went down, as Tom Frieden has pointed out. But if you allow one case, and in these remote areas one case can reignite the whole thing, and indeed that's what we have seen with a secondary spike that has been truly difficult to control. These investments have allowed us to work with WHO, UNICEF, to allow to deploy 30 or so technical experts, provide additional operational support, including 35,000 sets of personal protective equipment and supplies. Also the basics, soap, water, that sort of thing is also very important in this type of situation, and is taking place as we speak. USAID is closely coordinating its response to Ebola with the Department of State's Health and Human Services and Department of Defense, as well as with WHO. The CDC has the lead in the response to the Ebola outbreak, but the coordination, and I've been part of many other interagency efforts, has been truly exemplary, and I want to really point that out. It's been something the last couple of weeks that coordination has been working just to make sure that we actually support those countries to stop this outbreak. USAID, in addition, has activated a disaster assistance response team, a DART, something that you are familiar with, that we have deployed in other emergencies, from Fukushima to typhoons to Haiti earthquakes, and this provides the architecture for the integrated response of the U.S. government once the U.S. ambassador on the ground has declared an emergency, and this has indeed occurred, and the DART is now deployed in the team leaders and the deputy team leaders are in place. CDC is responsible for the health and medical part of this response, but there's plenty of other activities in planning, in operations, in communications, in engaging not only in the government of the USG, but with the local governments and with the other partners that I mentioned before. I spoke with our mission director in Liberia, where we have a large platform for health work that works very closely with the Ministry of Health. We have only one or so health staff in Sierra Leone, regular in Guinea, and in Sierra Leone we did not have a mission, and so it has been, we are building out of this DART and working with the CDC and others to have the required staff and experts on the ground to facilitate the report. I want to report that the morale is high in our teams. Although the family members have been ordered to leave the country, our teams are staying put, working with the CDC, working with MSF, working with others, taking all the precautions to ensure their safety, but also supporting them to work effectively against this outbreak. And this reminds us, of course, that an outbreak requires also a mindset of prevention, not only in the acute setting to avoid the growth of this epidemic, but also the global vigilance that we must maintain, since these viruses know no borders. In the short term, it is a humanitarian imperative and a national security priority to contain this Ebola outbreak as quickly as possible. It will take probably months to end it, but I think we can turn around these tables in the next couple of weeks if the robust response that is being mounted is deployed and executed as planned. The U.S. government is fully engaged in the response, and we are confident that we can stop the epidemic. As I said, it will not be easy, and it might take several months. In the long term, we must assist developing countries in strengthening their own health systems, both those dedicated to infectious diseases like this, but also the overall capability of the systems to deal, because it's about the frontline health workers in primary care settings, in communities, and this time is Ebola in Western Africa, We have seen H1N1 coming from Mexico. We didn't expect that. Or MERS coming from South Africa. These pathogens can jump anywhere, and health systems need to be prepared to deal with these things as they occur. With your support, USAID will continue to make this a priority in our global health investments in Africa. And as Tom Frieden has alluded also, the administration is working on the global health security agenda, for which we look to work with you in the plans, because they will require indeed support in the future. And we look forward to working with you on that. Thank you very much for giving me this opportunity, and I look forward to your questions.
Doctor, thank you very much for your testimony and for your leadership. I'd like to note we have been joined by Augustine Inufuan, who's the Foreign Minister of Liberia. Thank you for being with us today, Mr. Minister. And now I'd like to yield to Ambassador Williams.
Thank you very much, Chairman Smith, Ranking Member Bass, Chairman Wolf, and members of this committee for the chance to testify before you on this very important topic. The evolving Ebola crisis in Guinea, Liberia, Sierra Leone, and now Nigeria is one of the most daunting challenges those countries and the region have faced in decades. To date, more than 1,600 suspected and confirmed cases of Ebola have been reported, including over 900 total deaths. Although these affected countries are home to many heroic and dedicated health workers, the rapid spread of the disease reflects the lack of national capacity, particularly in the three epicenter countries of Liberia, Guinea, and Sierra Leone, to limit the spread of the disease and to treat patients. The NGO community, which has played a significant role in the response effort by providing frontline medical care to patients, is hard-pressed to continue to provide care in all affected regions. Compounding the issue, affected populations' lack of understanding of the virus and widespread mistrust of healthcare providers and treatment methods have further hampered response efforts. In significant portions of the affected regions, local traditions such as public funerals and cultural mourning customs, including preparing bodies of the deceased for burial, have contributed to the spread of the virus and have led locals to block access to patients, and in some places have led to attacks on healthcare workers. Following one such incident in Liberia, major care providers like Samaritan's Purse have begun pulling out of the region due to concerns for the safety of their staff. Thus, in addition to proper medical care, there is an urgent need for effective health messaging campaigns and public outreach as an integral and crucial component of these response efforts. We are reaching out to ensure our response is coordinated with the WHO and other countries that can assist, both through our representatives at WHO headquarters in Geneva and through direct discussion with other governments. Guinea, Liberia, and Sierra Leone are still rebounding from lengthy conflict. These conflicts destroyed lives, institutions, and infrastructure. This was especially acute in Liberia and Sierra Leone, where the fighting went on for years. These countries have taken important steps to reverse the effects of deterioration and neglect, and to build lasting security and stability. Border control and other factors key to checking Ebola's spread also are challenging for the countries in this region. Aside from our interest in making sure this Ebola virus does not spread to the United States or farther in Africa, we do not want the virus to erode the capacity of African countries to address other important national and regional challenges. We want to ensure these countries remain strong, strategic allies to the United States in a region facing serious development and security challenges. Sadly, this virus already has impacted peacekeeping in Somalia. The African Union canceled a planned deployment of Sierra Leonean peacekeeping force due to fears that the virus could be introduced into the country. Given the critical importance of this issue, we are fully committed to doing everything possible to shore up each government's efforts to combat the viral outbreak and control its spread. We are confident that through the concerted and coordinated efforts of our government and our international partners, we can contain and stop this virus. In fact, Mr. Chairman, the Department has established a monitoring group on the humanitarian situation in West Africa to monitor and coordinate information. The task force may be reached at the following email address. That's taskforce-5@state.gov. Since the beginning of the crisis, the Department has maintained close contact and coordination with the governments of all of the affected countries and has closely monitored their operational plans to combat the viral outbreak. In Sierra Leone, President Koroma directed government officials to make containment of the virus their top priority and set up a presidential task force to lead the government's efforts. In Guinea, improved messaging to the populace helped healthcare providers gain access to infected regions. And in Liberia, President Johnson Sirleaf announced a national task force to combat the spread of the virus. On August 1st, the three presidents detailed their collective strategy for eradicating the virus in a joint communique following a meeting of the Mano River Union. We commend all three countries for taking this outbreak seriously and for taking concrete steps to address it. This week's news of new cases in Lagos, Nigeria, a city of over 20 million people, makes the need for an effective, well-supported, and well-coordinated national plan and international response more important than ever. In fact, Mr. Chairman, I just met today with President Blaise Compaoré of Burkina Faso and with Dr. Kadre Ouedraogo, who's president of the ECOWAS Commission, who told me that the health ministers of the three affected states will meet again. They will meet in Conakry at the end of this week on August 11 through 14. And that following that, the health ministers of all of the ECOWAS states will meet in Accra, Ghana on August 28th. The intensified attention of the health ministers of the entire region is a good sign, and it demonstrates that the whole region is seized with this crisis. Assistant Secretary Linda Thomas-Greenfield has spoken to the presidents of Guinea, Liberia, and Sierra Leone to express support and to assure them of our assistance to stop the spread of the virus. On August 4th, the Department hosted and moderated a meeting on Ebola on the sidelines of the U.S.-Africa Leaders Summit to discuss the next steps for controlling and ending the virus. HHS Secretary Sylvia Burrell, CDC Director, my colleague here, Dr. Tom Frieden, and NIH Director, Dr. Francis Collins, USAID Assistant Administrator for Global Health, Dr. Ariel Pablos-Méndez, and President Alpha Condé of Guinea, the Liberian Minister for Foreign Affairs, Sierra Leone's Ambassador to the United States, and Professor Tomori Oyeyale, the President of the Nigerian Academy of Science, participated in the meeting. Representatives from DoD, from the NSC, the World Bank, as well as private partners like the GE Foundation and Becton Dickinson & Company also joined. In addition to emphasizing the need to focus on detection, isolation, and adequate training for health workers in the field, we also emphasized our long-term commitment to building the healthcare capacities of individual West African nations beyond this immediate crisis intervention. We continue to work with our international partners and the WHO to assess what is needed to properly treat patients and to mount a sustainable response. Such support has included providing financial and technical assistance to properly equip treatment centers and supporting communication efforts to help healthcare workers access affected communities. The WHO Sub-Regional Coordination Center opened in Conakry on July 23rd and is coordinating all surveillance efforts, harmonizing technical support, and mobilizing resources being provided to the affected countries. The organization has also launched a $100 million emergency response plan to surge resources to mount a more effective response. We are in continuous discussions to find new ways to provide assistance. The Department of State has no higher priority than the protection of U.S. citizens. We extend our deep sympathies to the family of Patrick Sawyer, a U.S. citizen who died in Nigeria after contracting the virus in Liberia. At least 2 additional citizens affiliated with the response organizations have been infected in Liberia and are currently undergoing treatment. We are in close contact with the sponsoring organizations of those 2 individuals, and our thoughts and prayers go out to them and to their families. U.S. embassies in the affected countries have disseminated security messages, including the CDC's warnings, to resident and traveling U.S. citizens. We continue to take steps to educate citizens about the virus, to dispel rumors, and to provide information on preventive measures. We also take the safety and well-being of our staff very seriously. To that end, the department's chief of infectious disease traveled to West Africa to provide embassy staff with assistance regarding protection measures and case recognition. Additionally, embassies in the affected region have organized regular town hall meetings to answer questions and concerns of mission personnel and U.S. citizens. Embassies in neighboring countries like Mali, Senegal, and Togo have also held meetings to assess the capabilities of their host governments and to make contingency plans for embassy personnel and resident citizens in the event of an outbreak. In closing, Mr. Chairman, I would like to reiterate and assure this committee that the Department of State takes the Ebola threat very seriously, and we are fully dedicated to working with our governmental and non-governmental allies, the interagency community, and host governments in the affected countries to respond to this crisis, prevent its spread, and to restore stability to the region. I thank you for your attention to this issue, and I look forward to answering your questions.
Thank you so very much, Ambassador Williams. I do have a few questions I'd like to pose to our distinguished panel. Beginning first, as Dr. Frieden, as you said, supportive services are important with no effective vaccine or drug treatment. You outlined how important those services are, including hydration and I'm sure antibiotics to deal with some of the other co-infections. Now, I wonder if you could just tell us, is there any disproportionality in result when it comes to whether or not we're talking about a frail elderly person, a woman, a man, a child, a woman who happens to be pregnant, or any of the other, someone who has a compromised immune system? What has been, the MO of that, if you could? Secondly, I know that treatment centers, for example, in Guinea, there are some 3 to 4 treatment centers. But again, it's very hard for people in that country, as well as the others, Liberia and Sierra Leone as well, to get to those treatment centers. It's a long trek. Very often, the ride could, not only the person is very sick, others could come in contact with him or her. There seems to be an overwhelming need. One of the points that I think needs to be underscored that is underappreciated in many places is that in dealing with someone who is dying, especially in that part of the world, there is a psychological trauma with being alone. So it almost exacerbates the spread of the disease because people want to be around, near, touching, and when that person is highly infectious, that's when family members and others might get it. If you could speak to that. The lack of testing areas, whether they be, as part of the treatment centers where there's a testing lab. It's my understanding, especially since this masks and parallels what other, it looks like other things, but it's Ebola. But unless you get that test back, how long does it take to do the test? And again, is there any way of standing up labs? I know for a fact that, especially through the work of Bush's PEPFAR program, which has been followed up with Obama, doing the same thing, and the idea of building health capacity and labs in Africa is a very high priority, and now we're seeing where inadequate labs or lack of labs leads to people being sick and not even knowing it. Let me ask you, the courage of the healthcare workers, I think needs exclamation points. I mean, and I know you are as well, and you go on the front line yourself and go into, all three of you, into contagious areas. But Dr. Brantley and Ms. Whiteball and others who put their lives on the line, motivated so often by faith in the case of Dr. Brantley. And I mean, I've read some of the things his wife has put out, the prayers that are being offered up, not just for him, but for all of the victims. In Liberia, there have been 60 healthcare workers infected, 35 are dead. In Guinea, 33 healthcare workers affected, 20 dead. How does a country now attract or retain healthcare workers who say, if I go into that arena, the prospects of me getting this are very real? Is there enough protective equipment? The gowns, the plastic, to mitigate that the possibility of transfer. And finally, and I do have other questions, but I'll yield to my colleagues. There are a number of, as I said at my opening, promising drugs. ZMapp is one of them. Certainly Tecmera, which was in phase 1 trials, and yet the FDA has a hold on it. They were contracted by the Department of Defense. From what I've read, and it's only from what I've read, that the available data, it was showing promise, and I'm wondering if there's any way to accelerate, knowing that you don't want to obviously put something out there that is risky, because Ebola is not 100% fatal, as we all know. We don't want to keep people getting sick from the remedy or supposed remedy. What about accelerating that? Is there an effort to do that? And my final question is about the safety of airline flight. Many people have contacted my office to ascertain, how safe is it to fly, perhaps next to somebody who's maybe changed flights en route to the United States, coming from Liberia, for example. And are the efforts at the airports, particularly where there's a large diaspora population, I don't know if you have enhanced efforts there, where there's people from West Africa are more likely to go, but are they up to the task of detecting at point of embarkation of passengers who might be sick from Ebola?
So let me try to quickly give you clear answers to all of those questions. The first is the relative case fatality rate of different groups. And in the current outbreak, the data is still too foggy for us to give you clear data. There is not the kind of robust data that we will have eventually but don't have now to give you what we would call the case fatality rate for different groups. But there is one very intriguing historical fact, which I think is worth mentioning. In 1967, there was a laboratory accident in Marburg, Germany. The Marburg virus was then identified. Marburg has a similar fatality rate to Ebola, if anything a little higher. It's around 80%. The outbreaks have been in the 80% range in Africa. The case fatality rate in Germany in the Marburg outbreak was 23%. Now, that might have been because of the better supportive care. There was no specific antiviral treatment. Or it might have been because people were healthier going in. We don't know. But we do know that it was dramatically different. And I think that's an important point. Good supportive health care is a proven way of saving lives. And we should never lose sight of that. Second, in terms of treatment centers, you're absolutely correct that there's a challenge in getting to treatment centers. And that's that is, in fact, the #1 priority for the DART team, which USAID is convening and CDC is leading the public health aspects of, which is on the ground today in Liberia to assess. And the biggest challenge is both in the city of Monrovia, where there continue to be chains of transmission, and in that tri-country area. So looking at whether one facility or multiple facilities and where the facilities would be, that's a critical issue for us to determine in the coming days. Treatment centers, as you point out, are very important to support. I was speaking with the American chargé from Sierra Leone, who was speaking very movingly about the patients and their isolation in the treatment centers, and simple things like giving them cell phones so they could talk to their family, or things that they could do while there was very important. And if patients don't believe that they're going to be well treated in the treatment centers, they won't come in, and they may continue to spread it in the community. So good quality care is very important. In terms of testing, you're absolutely correct. As you know, Mr. Chairman, with support from PEPFAR, the CDC has helped create the African Society for Laboratory Medicine, and that has, for the first time ever, had high-quality laboratories established all over Africa. These countries have not been PEPFAR-focused countries, so they have limited activities in that area, but scaling up laboratory testing is important. We'll do that in 2 ways. First, by finding laboratories. This isn't simple laboratory test. This is a real-time PCR. The results come back within a day, but false contamination, false positives are possible if you're not scrupulously careful, and that would be a real problem. So we will scale up the labs that can do testing, and we're working with international partners on this who are involved and with the Defense Department, which has a very active program, for example, in Sierra Leone, and is providing services there, and with the National Institute of Health and Institutes of Health, which has been very helpful. We'll also establish safe specimen transport means. We've done this in Uganda, where we can very safely transport. Hard to get a lab out all over, but quite possible to get transport into the lab, and that's what we'll establish in the coming days. In terms of the courage of healthcare workers, I certainly agree with you, and it's an issue not just for healthcare workers, it's an issue for patients. We've heard that with healthcare systems less functional, problems like malaria may become more deadly. So the impacts of Ebola aren't just Ebola. There are the other conditions that aren't treated because of Ebola. So responding is so very important, and protecting the responders is so very important. So a key aspect that we're working on with the World Health Organization, with the countries, with USAID and others, is making sure that there's effective personal protective equipment there for healthcare workers. We believe it is possible to take care of Ebola patients, even in Africa, safely, but it takes meticulous attention to detail. In terms of the promising drugs, I can assure you that the U.S. government is looking at this very carefully and will look at any way to try to expedite development or production, but I don't want any false hopes out there. Right now, we don't know if they work, and we can't, as far as we know, have them in any significant numbers. We hope that that might change, but these medicines that have been used in the experimental cases, as far as I understand it, are not easy to use. They require infusion. They may have adverse events. And basic supportive care needs to be in place as a prerequisite to giving many of these treatments. So whatever else we do, we have to do the basics right. And we might or might not have effective and available treatment in 3 months or 6 months or 1 year or 5 years, but we today have the means to stop the outbreaks. And finally, in terms of airline flights, we do have teams in the affected countries who are working with their basically the equivalent of their border patrol or border protection services, helping them to do screening at the airports. It's not a simple measure. It's key first to reduce the number of cases. That's what's going to be the safest. And there are other things that can be done at airports in terms of questions to be asked or temperatures to be taken or lists to be cross-matched against known patients and known contacts. But all of those procedures do take time to set up, but we do have teams working on them now.
Dr. Frieden, if I could ask you, if somebody is in proximity to a sneeze or a cough, is that a mode of transmission?
In medicine, we often say never. So in general, the way we have seen the disease spread is by close contact with very ill people. As you know, the individual who traveled from Liberia to Lagos did become ill on the plane, and we have assisted those countries to track the travelers who traveled with him, and as of now have not identified illness in any of them. But in general, it is not from a sneeze or a cough. In general, it's from close contact with someone who's very ill. But we do have concerns that there could be transmission from someone who's very ill. That's why.
So at the fever stage, if somebody is on board, is that would be construed to be very ill? You're not likely to get it from somebody who is at fever stage?
If you're not going to get it from someone who's not sick with Ebola. So if they're just clearing their throat or sneezing or coughing, but they don't have a fever, they've not become ill with Ebola, they're not infectious to others. But if someone became ill on the plane and was having fever or started bleeding, then, for example, that might present a risk to those who came in contact with that and didn't take appropriate precautions.
Is there a way of advising airline personnel, particularly flight attendants, who, again, might be in very close proximity to the whole plane, and there could be someone on there? Does CDC advise them and the airlines, like Delta, which flies numerous flights to the region? Yes,
we have provided detailed advice to the airlines.
Let me just ask you, Ambassador Williams, very quickly. You spoke, and I think it was a very good insight about the handling of for funeral arrangements and just generally that sensitivity to the culture. I know it's part of the public information campaign in Guinea, for example. Some 9 million cell phones are being used, and text messages are being sent with a number for the Red Cross, and it's. One of the text messages are, the bodies of Ebola victims are very contagious. Do not manipulate, call the Red Cross. Now, I'm wondering if there's any thought being given. I remember after Operation Provide Comfort, when the Kurds made their way to the border of fleeing Iraq after Saddam Hussein. I was there about 5 or 6 days after that, and our military was on the ground, and they were using PSYOPs to educate and leafleting that was done in a way that we would use in a not-so-benign situation. In this case, it was to get food out and meals ready to eat. And it was amazing how that kind of information made the Kurds, who were at great risk of the elements and starvation, very aware of what they needed to do. Is there any thought of helping the Liberians and the other countries with a again, a benign PSYOPs effort to make people aware. I know that radio is being used, but it seems to me that more needs to be done. Any thoughts?
Thank you, Chairman. I can't say that we've moved to the point of PSYOPs, but I think you are hitting a very, very important issue, which is that culture makes a difference, and you have to adjust your messaging and do the campaign according to the sensitivities and the routines and the practices per culture. What was extremely effective in Guinea was not only what you mentioned, Mr. Chairman, but the fact that they started talking about survivors, and the survivors came on the radio. They went around and said, "Look, I was sick, but this and this and this happened to me. I did such and such, and I'm still alive. You should go get treatment. You should isolate. You should make sure people know you have this." So that's very, very important. Our military right now is helping in the ways that have already been described, as far as with logistics and making sure that we can get in body bags, protective equipment for the healthcare providers, and that's where we are so far. But we are relying upon the host governments to help explain to us what are the most effective, what are the sensitivities, and what messaging needs to get out, and then we are helping with the means of the communication, but not the actual message, because they know best what the people need.
Thank you. I yield to Ms. Bass.
Thank you very much, Mr. Chairman. This is for the doctors. I wanted to know if you could talk a little bit more about the disease in terms of, we all know about fevers, but having spent a number of years working in emergency rooms, I can imagine what's happening in our emergency rooms around the country. Everybody with a fever is running in, being concerned. And I was wondering if you could talk a little bit more about what are the other symptoms of the disease. And maybe if you have any thoughts of why some folks are surviving, since my understanding of part of the disease is that it interferes and takes over with the immune system.
So the fevers can be one symptom, but chills, weakness, nausea, vomiting, diarrhea are other symptoms. In about 45% of cases, there is bleeding, both internal and external, and that's a feared complication. So these are symptoms which, as you've both pointed out, are not specific to Ebola. And that's why the laboratory testing is so important. It's also why it's not the case that someone will know they have Ebola and go to a special Ebola unit, and why it's so important that health facilities who are there think of the risk of Ebola and then rapidly isolate people. In this country, what we've told healthcare workers to do is take a travel history. Has the person been in one of these countries in the past 21 days? If yes, and if they have fever or other symptoms, then do tests. We've already had 5 people in different parts of the U.S. who've come in with a travel history to one of these countries in the past 21 days. All 5 have turned out not to have Ebola. 2 had malaria, 1 had influenza, and 2 had something else. So we expect this to happen. In fact, we want there to be a high level index of suspicion so that doctors will rapidly isolate the person and then rapidly test them.
And how do you screen? Just as the chairman asked, and I know, again, what's in the press is that if someone on an airline sees someone with a fever, and I mentioned to you yesterday when we spoke, there's these pictures in the news of the wands, or they're doing some type of screen, and I think you pointed out, and maybe you could talk about that's really not effective. So how does one screen short of a blood test in a medical facility that like an airport worker might do?
There's no way to diagnose Ebola without a laboratory test. So if someone has fever and they may have been exposed, they've been in one of these countries, they need to be isolated and tested. For people within the U.S., currently both we have a test that's accurate and relatively quick, a few hours once the specimen gets to our lab, and the Department of Defense also has a test. And we're working in collaboration with them to see if we can, over the next couple of weeks, get that test out to what's called the Laboratory Response Network, or LRN. This is a network that CDC coordinates of laboratories at mostly health departments around the country to test for dangerous pathogens. Ebola is not in their usual network, so this would be a new procedure, but either through the Defense Department's assay or our own, we will look into getting that available so not all of the tests have to come to CDC Atlanta and they can be tested locally. We also have safe ways for specimens to be transported to CDC if they need to be transported.
One of the other things that we've touched on a couple of times today is the ZMAT. I believe that's what it's called. And I would like for you to talk a little bit about that because there's a lot of concern that maybe we have access to this and are not providing that access. And one of the things that I think was mentioned that maybe you can elaborate is that there might only be just a couple of doses that were even made.
So first, I really would need to refer you to the National Institutes of Health, which would be the lead on developing new treatments and vaccines against Ebola. The information I have on that medication is quite indirect. What I understand is that it's a combination of different monoclonal antibodies. This is part of what the body does to respond to an infection, and that there is some evidence from at least one animal study that may have some effect on the illness. However, I think I would caution that we really don't know. I think that has to be emphasized. Even whatever happens with these two individuals, and we hope that they and every other person with Ebola will get better, as some people do. But we will not know from their experience whether these drugs work. Antibodies are only one part of our response to an illness. There are many different parts of the immune response. In some other conditions, antibodies can actually make the disease course worse. So we don't know until it's rigorously studied scientifically. I also cannot tell you definitively how many such courses there are. I've heard that there are a handful, fewer than the fingers of one hand, but I have no direct information on that. Other manufacturers are coming forward to say that they have some or could make some. We've heard from some companies that it would take months to make even a few dozen courses. So I think this is rapidly changing information. I don't have definitive information and would refer you to the National Institutes of Health, but let's always go back to the basics, that we know now how to stop Ebola, and if a person has Ebola, we know how to support them to reduce their risk of death in proven ways by treating and preventing other infections that they can get when they're sick, by providing hydration, fluids, careful management of their health condition, blood transfusions if they need them. These are proven things. If there's a new treatment, we will do everything we can to help get it out to those who need it most. We would also be very interested in a vaccine. If there were an effective vaccine, we would offer it with full informed consent to healthcare workers as a way of helping them protect themselves. But right now, we are months or at least a year away from everything I've seen and heard, from significant quantities of either drugs or a vaccine, even if everything goes well and we're able to develop them. That could change, but that's the information as of now. What's available to us today, right now, is the means to stop the outbreaks in Africa.
It's not helped when it's reported that the one individual had a miraculous turnaround and was able to walk out of the ambulance because he had gotten the treatment. You know, that leads to the belief that there's some kind of cure out there that we know about that we're not sharing. In looking at the death rates at the different countries, there's a difference. In Guinea, it's 74%, Sierra Leone, 42%, and Liberia, 55%. And I wanted to know from the panelists, what do you see as causing the difference? And is it a situation where each of the countries have addressed the outbreak differently? Capacity, commitment? What is the difference?
I think in terms of the death rates, the data is still very fluid. And it's not clear that each of those rates is actually comparable, given the different ways cases are diagnosed and counted and reported. What is the case is that for each of the countries, they have their own challenges. I would say that the country of Guinea is probably furthest along in responding. They've reduced their number of cases, but there too, they have continued spread in healthcare facilities. And that tri-border area, the map that shows that area seems to be a core epicenter. And security problems in Liberia, for example, have led to treatment facilities not being available in Liberia, patients moving over to Guinea, and then re-importing the disease there. So it really is a regional response that's needed for the three countries, and that also will be a core first deliverable of the DART team that USAID is leading and CDC is leading the public health, healthcare, medical aspects of, to identify in that region what can be provided rapidly to assist with caring for patients to allow us to reverse the outbreak.
Yes, if I may add, in addition to the difficulty in establishing the denominator to calculate that percentage, is the point that Tom is referring to, the fact is that across, nonetheless, even if there were more cases that we are not recognized, deaths are more likely to be recognized than cases. And so the percentage can vary in that. But on the whole, we are seeing that the disease is indeed quite deadly, but not universally fatal. And that's very important. And in Guinea, this has been a very important part of the strategy of educating the public. Because if people think that you're going to get it, you're going to die,
right,
then there's no motivation to go to the services, to protect the families. And so the education has been paramount. And in Guinea, we have seen a plateau of the outbreak in the last month or two. There's still some, especially because of the border area. But on the whole, the response that Guinea has implemented and the education in this case has been very important, both for the patients again and for the health workers. We are now doubling up to 70,000. The personal protective equipment will be available. We had already in storage in Ouagadougou in the region, and that's what we got going through the spring. We are having more now than equipment that is to be prepared to protect those health workers. And it was raised before, and I want to emphasize, health workers are trying to do their best to save lives of other people. And so the 120 plus of them who have already died in this outbreak are true heroes. And I think that support for the health workers will be paramount, and I think that we are very committed to doing that. When we mentioned earlier, the State Department has advised the families of our staff to leave the countries. It's not so much because they are in immediate risk, but because the health systems are already so overwhelmed that if you had anything else, there's nowhere for you to go to. And in addition, for many of those, if I may add also, is that kids who will start school soon, the schools may not be opening. So the asking the family members to leave is wise, not because they are in immediate danger.
You know, Dr. Pablos-Méndez, I think you've mentioned a couple of different figures, and maybe I've confused them. I think you said 70,000 and 35,000 pieces of protective gear. And I was wondering if those have reached the affected, well, number one, what was the difference? Did I get them mixed up, or maybe it was at different times? And then two, has it reached the area? Because I mentioned earlier speaking to Dr. Johnson, and President Johnson, and she was very concerned and expressed the need for additional units of protective gear.
Thank you. The 35,000 units were indeed part of the first batch that we mobilized early on in the epidemic. We already had some of them in strategic storage locations, one in the region in Ouagadougou that has been made available now. The question is the logistics of distribution, and that's where our DART team now deployed will support the countries to make sure that they reach all the frontline workers that will be required. But with the additional resources we're mobilizing now, we will reach 70,000 of such is the space suits that you have seen.
Right.
And we have now is the production part, and they have to be prepared. They don't come just ready to use, and that's where we are right now. But we expect to reach 70,000 of such PPEs, as we call them, to reach where important. We have also in neighboring countries some of this training. We have some of those available to them, just at least to become familiar in case that we need to scale up. And we have all along modeled how this could spread. And indeed, as Nigeria has been one of the nodes, Ghana has been another that we are paying attention, because in our models, that suggests that that could be a route where the airlines flights could allow this to escape the countries that we have it in today. So we are preparing, and we have trainings, and we have some of the equipment already available there.
Thank you. Ambassador Williams?
Yes, thank you. I just want to clarify, as I said earlier, we are continuously monitoring the situation in all of the affected countries, and our primary responsibility, our primary concern is the health and welfare of American citizens abroad, our embassy staff as well as residents. We have not, in fact, ordered the departure of our family members from any of our places, although we are of course, it's one of the things that occurs to people. It's been one of the things under consideration. But at this time, we haven't. And I know that since we do have an interagency coordinating committee that's been talking about a number of things, it has been among the things we've been considering. But as
so USAID has had
No American personnel, no American official personnel or their families have been ordered. It is one of the options under consideration, but we were continuing to look. As was stated, you know, our families, our dependents follow the government officers all over. We're on the front lines every day all over in very dangerous places. And bearing in mind the stresses in the various countries now and the concerns, the anxiety levels among some of our families, it's something that has been discussed. But at this point, we have not ordered the departure of any of our family members. I just wanted to make sure you understand.
Okay, and the last question is, I think it might have been one of the panelists referred to the security issues in Liberia. And, you know, when I spoke to President Johnson yesterday, she didn't mention that, but when I was watching the news this morning, there were, you know, the text messages that come across the news said that she was very concerned about it, and I wanted to know if maybe you could address what are the security, what is happening? Is this something new, or are we talking about?
What I was trying to stress is putting in the framework, you know, these things happen in a context.
Right.
And it's one thing to have this health crisis, but in fact, the country was already still trying to build itself up from a rather torturous past.
Oh, okay.
So the president of Liberia did declare a disaster in her country as a result of this crisis because she really wants the international community to pay attention. And she's trying to also explain to her people why she is mobilizing an intensified force to specifically focus on Ebola. But there is no new security external threat to it.
Thank you. Thank you, Mr. Chair.
Thank you. Chairman Wolf.
Thank you, Mr. Chairman. In what country did this first begin?
The first cases were reported from Guinea, but it's really possibly, we don't really know at this point, or I don't know at this point, the history of it, but the epicenter is that forested area that has the confluence of the three countries.
Ambassador Williams, over the years we have heard from ambassadors and embassy staff that Washington does not take cables from them seriously. When did the State Department in the District of Columbia and Washington here first get a cable notification from the embassies of Sierra Leone, Guinea, and Liberia about the Ebola crisis?
Chairman Wolf, I will, if you mind, I'm going to look through my notebook to see if I have the exact date. I'm not sure I have the exact date. So if you just give me a second.
Sure.
Mr. Chairman, I'm going to have to look up the cable. I don't have the cable traffic. I will say, however, we are in daily communication with our embassies, and if not through cables, through emails, through telephones, we are in constant control. But I will find the specific answer to your question and get it back to you.
It's, you were an ambassador. It's often we hear, and as you know, my district in Northern Virginia, we have many, and they say that sometimes the cable gets sent, and they wonder if, so I'd like to know when the cables were sent, and secondly, how high in the State Department were the concerns raised, at what level and what time?
Thank you, and I'll take the question. I have to find the exact date. We've been aware of this for a while now. We're working on it. And as having come out of the region as an ambassador, as it was stated, I was our ambassador to Niger up until 2010, the end of 2010. And covering West Africa in the Bureau of African Affairs, I'm seized with this. I'm paying close attention to what the embassies are saying. I know what ambassadors and the people there are going through, and I will get the answer to your question as soon as possible.
You mentioned the work and the response of AID and state and others. What other donor nations have gotten involved in the efforts, and what exactly are they doing? Can you give us a list of the countries? You said, Dr. Frieden, you have 40 to 50 people coming. Can you tell us what England's doing and what France is doing, and give us some specifications as to numbers and how they're cooperating? Because it all cannot be the United States. What are our European allies and others doing? In numbers, if you can.
I think it would probably be best if we got back to you with details. It's something of a moving target. I can tell you that the French, through the Institut Pasteur, have been very active. They have laboratory services and other services there. The British have also been very active and have provided both resources and people on the ground. We had an announcement earlier this week from the World Bank of a commitment of $60 to $70 million for emergencies, as well as the emergency response, as well as a longer-term response. The World Health Organization, as you may be aware, issued an appeal recently for $100 million to respond to the outbreaks, and we've been in close coordination with many of our colleagues around the country, around the world, excuse me.
Well, has the White House asked them to be involved? For instance, the Germans have a history in Africa. The French have a history in Africa. The British have a history in Africa. Has there been a formal request by the White House to the heads of those governments that they participate to help your effort?
We've had intensive conversations with multiple other countries. Were you going to say something, Dr. Pablos?
The answer is yes. There's been, the ambassadors in Geneva had met for the various countries, and as you pointed out, there are many historical linkages. The British government in particular is supporting the response in Sierra Leone, France supporting the response in Guinea. We have a strong presence, really hand in glove, with the Ministry of Health in Liberia. We saw our response has been particularly important there. As Tom has mentioned, the emergency plan that WHO put forward just over a week ago is for $103 million. They originally got about 30 million of that covered to begin moving, including some of the support that we have been providing, with the World Bank coming through also just this week with an announcement of $200 million that will allow us to fill the gap in the WHO plan for the immediate response, but in addition, will invest in the months to come in strengthening the systems in that part of the world. So many of these pieces, and as we speak, many of these things are moving very fast. So we are trying to continue that conversation. But in Geneva has been a focus for the various countries, donor countries, to be having periodic updates as to how much more resources. But that geographical location of division of labor, if I can put it that way, is already underway, even though CDC's presence is in all of these countries.
Is the African Union engaged?
The African Union has been engaged. The African Regional Office of the World Health Organization in particular has been engaged. And to your earlier question, in Liberia, March 27 was when the first cases were reported. There was only a dozen or so cases, and then the outbreak fizzled. And this is typical of these outbreaks in Central Africa. And for a month, there were not many new cases. So in fact, the early behavior of the outbreaks was like the behaviors we have seen in previous outbreaks, and it's only as it was rekindled again in this three-border area that we have seen the expansion, particularly in Sierra Leone and Liberia, whereas in Guinea, it has been, after the initial outbreak, a more sense of containment.
Are the Chinese involved who have historically invested in soccer stadiums in Africa? Are they involved? Is the Chinese government that has invested in soccer stadiums in Africa, are they involved, the Chinese government?
We would have to get back to you about their involvement.
Madam Ambassador, can you tell us if you're with the State Department?
Yes, I'm from the, I'll have to look into that. I haven't heard about the Chinese involvement at this point, but I'll check. But I would like to reiterate, you were asking about the African Union. As I mentioned earlier, the ECOWAS states, the subset of the regional governments, are very seized with this, and they are meeting this week and then again in 10 days after that.
The last question, Mr. Chairman. If someone wanted to raise a question, call somebody, do something, had a great idea, who do they call? Is there one person? Is it CDC? Is it the Secretary of State? Is it AID for our friends here in the United States but abroad? Don't you need one person? Is there one person and one place and one number that someone can call? Because on the 28th, it was very difficult bouncing from here to there. And let me just say again to Dr. Frieden, he took a call, came off the airplane, did it. But he's going to be doing, is there one place that we would go to, someone would go to?
For response to any potential case or problem here, that's the CDC.
And what about if a nation abroad wanted to contribute, wanted to be involved, had an idea? Who do they contact?
In terms of the global collaboration, the key there is to support the World Health Organization, which really is the lead for the overall response.
And is there an individual there at the World Health Organization who's responsible, that is your person contact?
Yeah, that would be Dr. Keiji Fukuda.
Okay, okay. Thank you, Mr. Chairman. Thank
We
you.
just, before we go to our next panel, just if Ms. Bass has any additional questions, I'd certainly recognize her for that. How accurate is the data? Data in even the best and most pristine of situations often is very hard to obtain, but here we're talking about proximity issues, difficulty of ascertaining what's really going on. There was a doctor there was a report on CBS News that suggested that there may be as much as 50% higher prevalence of Ebola, and I'm wondering if you might want to comment on that. Is there any underreporting? And that's both of cases as well as fatalities. And then secondly, I know that the FDA is notoriously slow and notoriously comprehensive, and I don't want to either exaggerate or understate, but ZMapp, TKM Ebola, and that again was contracted by our own Department of Defense to work on that, and yet those clinical trials have been halted, phase 1. And I'm just wondering if there's any effort to rethink that, because this could take off. Those who have lost their lives that are sick, it is a tragedy beyond words, but many more could become sick and die as a result. Is there an effort interagency to say, let's relook at that? There might be some reason to lift that phase 1 trials halt to see if we ought to get at it. And finally, in his testimony today, Mr. Isaacs of Samaritan Purse, again, the man with whom I and Congressman Wolf spoke to last week, who had a profound sense of urgency and thought that we needed all to be doing more. He said it took 2 Americans getting the disease in order for the international community and the United States to take serious notice of the largest outbreak of the disease in history. Yesterday, the president of Liberia declared a state of emergency in the nation. This declaration, he goes on, is at least a month late. And I'm wondering, not only with the countries that are already malaffected, the 4 of them, what might be the 5th or the 6th? Is there a sense that there's a heightened concern about another nation, particularly one that might be contiguous with these 4?
So in answer to your first question, yes, we think that the data are not as accurate as we would like. There may be cases counted as Ebola that are not, and there may well be many cases not counted that are. The lack of treatment facilities, the lack of laboratory facilities make it so that the data coming out, it's kind of a fog of war situation, if you will. And that's one thing that we want to try to resolve quickly by getting laboratory, epidemiologic, but if there aren't treatment facilities, the patients won't come forward and we won't be able to do the control activities. In terms of the FDA, there are calls at least once, sometimes 4 or 5 times a day on coordination. I can tell you that they are leaning very far forward on this, and they're quite willing and quite constructive and productive in thinking of how to get things out there sooner if there's anything available. I think on the one hand, we have to do everything we can to try to find new tools. On the other hand, we have to recognize that we have the tools today to save lives and stop the outbreak. And in terms of future countries, we can't predict where that might be, but we do know that an outbreak anywhere is a threat everywhere. And one of the reasons we've focused on the Global Health Security Program is that we have the international health regulations, which require countries to report outbreaks and new diseases so that we can all, as a global community, work together, because it's in all of our best interests, not only to protect health, but to protect the economy, to strengthen our work in this area.
I want to thank our very distinguished panelists for your extraordinary service for the sick and at risk, and for being here today and helping to enlighten our subcommittee, and by extension, many other Americans who are tuning in and watching this. Thank you so very, very much.
Thank you.
I'd like to now introduce our second panelist, beginning with Mr. Ken Isaacs, who serves as the Vice President of Programs and Government Relations for Samaritan's Purse. Ken Isaacs has served as the Director of the Office of Foreign Disaster Assistance within USAID. He coordinated the U.S. government's response to the Indonesian tsunami, the Pakistani earthquake, humanitarian relief efforts in both Darfur and southern Sudan, as well as the Niger and Ethiopian emergency responses. Mr. Isaacs has more than 27 years' experience working in the relief and disaster response fields and has led major efforts in dozens of countries, including the ones I just mentioned. He is currently leading the Samaritan Purse organizational efforts in Liberia in response to the Ebola epidemic. We will then hear from Dr. Frank Glover, who is the director of the Urology Institute and Continence Center in the Urology Institute Ambulatory Surgery Center. His discovery of the world's highest rate of prostate cancer in Jamaica has been internationally recognized and published in numerous journals and textbooks. He and his wife founded SHIELD, or Strategic Healthcare Initiative Emphasizing Local Development, which is dedicated to building a medical school in Liberia, training resident doctors in various medical and surgical specialties, and providing loan forgiveness for Liberian doctors that have trained in the United States and who would like to go back and be involved in teaching doctors and serving patients in Liberia. Dr. Glover has been involved in efforts to treat Ebola in Africa since the early 1990s. Mr. Isaacs, please proceed.
Thank you. Chairman Smith, esteemed members of the Council, and fellow guests of this committee, I'm privileged to testify before you today on the developments of the Ebola outbreak in West Africa and Samaritan's Purse experience and response there. I'm going to read this first page so I don't overlook any of the things that I really want to say, and then I'm going to put the script away and I'm going to say the things that I feel like need to be said. Samaritan's Purse is an international NGO with 38 years of experience dedicated to humanitarian relief. We've worked in over 100 countries, including Afghanistan, North Korea, South Sudan, Syria, and Liberia. As an organization, we have responded to medical emergencies such as the cholera epidemic in Haiti, and we have provided medical care to the people of Bosnia, Rwanda, and Sudan during the genocides in those countries. The Ebola outbreak has had a profound impact on our organization, and I would like to share with you about our experience in Liberia. I want to take this opportunity to thank the United States government, particularly the Department of State, the Department of Defense, for assisting Samaritan's Purse in the evacuation of our sick personnel from Liberia. We could not have done it without them. And we'd especially like to call to attention and thank Kathleen Austin Ferguson of the Department of State, Dr. William Walters of the Department of State, Phil Scotty of the State Department, Mr. Dent Thompson and Congressman Wolf, and yourself. We would also like to thank certain staff members of the CDC and the National Institute of Health for bringing to our attention and obtaining the experimental medication as a treatment option for our 2 infected staff members. As an organization, we have worked to contain the growing Ebola crisis in Liberia, and we were devastated to discover that 2 of our personnel had contracted the deadly virus while trying to assist others. The support that the U.S. government has shown to our organization is tremendous, and Samaritan's Purse thanks you for helping us bring the 2 of them home in the face of incredible challenges. The Ebola crisis was not a surprise to us at Samaritan's Purse. We saw it coming back in April. Our epidemiologists predicted it. By the middle of June, I was having private conversations with senior government leaders, and by July, I was writing editorials in the New York Times saying that this was out of control. In the 32 years since the disease was discovered, as I believe Dr. Frieden said a moment ago, there were a total of 2,232 known infections, which killed 1,503 people. Easily, this present outbreak is going to surpass that in fatalities as well as overall cases. It is clear to say that the disease is uncontained and it is out of control in West Africa. The international response to the disease has been a failure, and it is important to understand that. A broader coordinated intervention of the international community is the only thing that will slow the size and the speed of the disease. Currently, WHO is reporting 1,711 Ebola diagnoses and 932 deaths in West Africa. Our epidemiologists and medical personnel believe that these numbers represent 25 to 50% of what is happening. The ministries of health in Guinea, Liberia, and Sierra Leone simply do not have the capacity to handle the crisis in their countries. If a mechanism is not found to create an acceptable paradigm for the international community to become directly involved, then the world will be effectively relegating the containment of this disease that threatens Africa and other countries to 3 of the poorest nations in the world. I know that a part of community and development philosophy is to work with your local partner and build the capacity. The capacity that is needed in the nations that are fighting Ebola should have been built 3 to 5 years ago. But in the times of crisis, I believe that the attention needs to be put on the crisis, and the building of the capacity should be a secondary function. We undertook a massive public awareness campaign in Liberia starting in April, and we have had over 435,000 people go through that training. But there are 3.6 million people there, and the majority of them are illiterate. It is not going to be easy to change the way that people think and what their cultural mores are. In the first months, we were able to provide support to the World Health Organization, the CDC, the Ministry of Health, and Doctors Without Borders, also known as MSF, with our 2 aircraft. The only 2 aircraft in Monrovia, in Liberia, that were flying support. We flew personnel, supplies, and specimens back and forth across the country. It makes the difference from the triangulation area that Dr. Frieden was talking about, also known as FOIA, to Monrovia. It reduces it from a 16-hour road trip to a 40-minute helicopter flight. I do want to take this moment to recognize and thank our co-workers and Doctors Without Borders for standing in the trenches with us. They are still in Sierra Leone, they are in Guinea, and they are now filling the gap for us in Liberia as we have had to pull back while we replan what we are going to do next. If there was any one thing that needed to demonstrate a lack of attention of the international community on this crisis, which has now become an epidemic, it was the fact that the international community was comfortable in allowing 2 relief agencies to provide all of the clinical care for the Ebola victims in 3 countries. 2 relief agencies. Samaritan's Purse and Doctors Without Borders. It was not until July the 26th when Kent Brandley and Nancy Wrightbull were confirmed positive that the world sat up and paid attention. Today, we're seeing headlines every day of Ebola fears. There is a man who has bled to death, evidently, in Saudi Arabia, and the Saudi government has confirmed it was a hemorrhagic fever, and he came from Sierra Leone. There was a man, a Liberian American, who came to Elwa Hospital with one of the most prominent physicians in Liberia, and that physician openly mocked the existence of Ebola. He tried to go into our isolation ward with no gloves, no protective gear. It's not an issue of gloves and a mask. It's an issue of no millimeter of your skin can be exposed or you will get sick and most likely die. That is sort of the reality of it. Those 2 men left our hospital. They went to the JFK hospital in downtown Monrovia, where the doctor did examine Ebola patients, and he was dead 4 days later. The other man was dead 5 days later, but not before he went to Nigeria, and now there are cases of death from Ebola in Nigeria, and there are 8 more people in isolation. Our epidemiologists believe that what we are going to see is a spike in the disease in Nigeria, and then it will go quiet for about 3 weeks, and when it comes out, it will come out with a fury. As I'm talking to you today, we are making preparations for a hospital that we support 263 miles north of Lagos on what they are going to do when Ebola comes to them. To fight Ebola, I've identified 4 levels of society that need intensive instruction because they simply do not understand what's going on. One is the general public. The custom that they have of venerating the dead by washing the body, I'm going to be graphic because I think people need to know, a part of that is kissing the corpse. In the hours after death with Ebola, that is when the body is the most infectious because the body is loaded with the virus. Everybody that touches the corpse is another infection. We have encountered violence against us on numerous occasions by people in the general public when we have gone out at the request of the Ministry of Health to sanitize a body for a proper burial. This is going to be a tough thing to do, so you've got this general awareness in the public, in the general public. The number 2 area that needs to be addressed is community health workers. The entire international community has built a medical system around community health workers, which is essentially a moderately educated person who is given a few simple medical supplies, an algorithm chart. If it hurts here, are you passing blood, do you have a temperature, give them this color pills. The doctor can talk about this more than I, but I think generally, I'm getting this right, they do not have the information to understand what Ebola is. Friday, 3 weeks ago, this Friday, at Elba, we had 12 patients with Ebola present. 8 of them were community health workers. Every one of those health workers had seen a patient, had diagnosed them for whatever they thought they had, and then they saw other patients. We have no way of knowing how many other people they have come in contact with. The third level of society is actually medical professionals. Something needs to be done with a focused attention on medical professionals, because when I hear reports that prominent physicians who are educated and credentialed and respected deny the disease, I think they need a little bit more education. And then the fourth level is leadership in politics, academics, and religion. I don't know how to make those things happen, but those are the 4 stratas that I see to turn the disease back. I think the entire fight on the disease has to be focused on containment. To contain it means you need to identify it. The previous panel up here was saying that it could be contained, that we have the information. Okay. Liberia, Sierra Leone, and Guinea are poor. Like all countries, they have their problems with pointless bureaucracy, dysfunction, and corruption. I know for a fact that in Foya, the second largest center where Ebola is manifesting in Liberia, the workers at the Ministry of Health clinic were not paid for 5 months, even after the European Union had put money forward. The money just didn't get downstream. Again, I will say that Ebola is out of control in West Africa, and we are starting to see panic now around the world. People want to know. I don't know about you folks. I look at the Drudge report. It can drive a lot of panic. And, you know, there's a guy in New York. There's a woman in England. There's 6 people have been tested in the United States. There are reports that there are 340 Peace Corps workers coming back. I greatly appreciate the help of the CDC. They have, in fact, Dr. Frieden and I personally have spoken, and they have, in fact, helped articulate their procedures and protocols for Americans returning into this country. And we are grateful for that. While our Liberian office remains open, doing public awareness campaigns, we have, in fact, suspended all other program activity. I would say that we are in the process right now of backing up, replanning, and reloading. We intend to come back and we intend to fight the disease more, but we have found some things that are needed. One of the things that I recognized during the evacuation of our staff is that there is only one airplane in the world with one chamber to carry a level 4 pathogenic disease victim. That plane is in the United States. There is no other aircraft in the world that I can find. That means that the United States does not have the capacity to evacuate its citizens back in any significant mass, other than unless the military or the Defense Department has something, DOD has something that I'm not aware of. It was not hard, I mean, it was not easy to get the plane back, but one thing that is important is if the United States, and I believe the United States is going to have to take the lead on this. It may not be popular for us to take the lead today, but I think that we need to take the lead. If we are going to expect people, including the CDC people, to go abroad and put their life on the line, there has to be some assurance that we are able to care for them if they are sick. That may be a regional health care facility that is exclusive to those citizens and those workers, or that may be a demonstrated capacity to get them home. But one airplane with one chamber to get them back is a bit of a slow process. Lastly, I think I want to say it is a necessary thing that more laboratories be set up just in Liberia. The one laboratory now is at JFK Hospital. There is another one up at over in Guinea and Gekadu, and it can take us sometimes 30 hours to get a sample back. I have had discussion with the CDC about this. I think that's under consideration, but I would ask you if you could lean into that and question that, that would be very helpful. The problem is if you have 6 people that come in and 3 of them or 4 of them are suspected, you have to put them in a semi-quarantine area, and you're holding that area of your case management center until you get a positive or negative back on them, and it takes time. I understand that the World Bank has just committed $200 million to fight the disease. That's fine. That's good. It's a little late. It's good. As somebody with 26 years of experience, including being the director of OFDA, running many darts around the world, interacting with governments on multiple levels, I have some practical questions. I would like to know where the money will go. I'd like to know what it will actually produce, and I would like to know what it will actually buy. I fear that money alone cannot solve this problem. I disagree with earlier testimony that there is PPE in Liberia. That is inaccurate. I have an email that I've just received in the last 90 minutes from our hospital, the SIM hospital at Elwa. They're asking us for more personal protection gear. This is a problem everywhere. I'm in touch daily with the headquarters of MSF in Brussels. We're working hand in glove. I appreciate them so much for the way that they are stepping in and fighting this. The biggest challenge that we all have is the logistical support to get the materials and the supplies on the ground to fight this disease. As one of you quoted something that I said earlier, if we do not fight and contain this disease in West Africa, we will be fighting this disease and containing it in multiple other countries around the world. And the truth is, the cat is most likely already out of the bag. I want to thank my staff and recognize them for who have been there and have done a valiant job at great risk to their own lives. I want to let you know that the reintegration back into their country is awkward. People are afraid to get around them. Their husbands and their wives don't know if it's safe to hug them. Their communities may ostracize them. We are doing everything that we can in a staff care way to give them a safe place to be, to protect their privacy. But I just want you to know how difficult it is for American citizens, and in fact, citizens of all countries. We have people on that team that came from more than 6 countries, maybe 7 countries. They all suffer these issues. I believe that this is a very nasty, bloody disease. I could give you descriptions of people dying that you cannot even believe. But I think that we have to fight this disease, and we have to fight it now. We're going to fight it here, or we're going to fight it somewhere else. I'm talking about here in West Africa, but I do believe that an international coordinated response, something significantly more, is needed. Thank you.
Thank you very much, Mr. Isaac, for that testimony. And again, I think underscoring your experience as head of the Office of Foreign Disaster Relief, I mean, you have lived it. And I don't think your resume tells the full story, all those years of dedication. So again, thank you, and we will take extraordinarily serious your recommendations and the questions you've posed, and I thank you for it. Dr. Glover.
Thank you, Mr. Chairman and members of Congress, for the opportunity to share with you. My name is Dr. Frank Glover, and I'm a board-certified urologist. I earned my MD degree at Johns Hopkins, and also the Doctor of Public Health and International Health Systems. I've also done some work as a research fellow at Johns Hopkins in epidemiology. I'm also a medical missionary working with SIM, which is a Christian missions organization with works in over 60 countries. In addition to working with SIM, I'm the president of SHIELD in Africa, a US-based NGO working in Liberia. My first experience in Liberia was in 1988, when as a medical student, I spent 2 months doing medical missionary work in an SIM hospital called Elwa, Eternal Love Winning Africa. For the past 3 years, I've spent 4 months per year working in various hospitals throughout Liberia. I've taken teams of up to 50 doctors and nurses several times per year. During this time period, we have taken care of thousands of medical and surgical patients. I've spent time rendering services of teaching, training, and patient care in most of the counties in Liberia. I have, therefore, had the opportunity to assess many of the hospitals and clinics throughout Liberia. In every case, the hospitals were understaffed and lacking in many basic essentials and pharmaceuticals. This Ebola outbreak in Liberia has exposed the country's inherently weak health system. Less than 200 doctors existed in this country of 4 million prior to this epidemic. After the outbreak in March of this year, that number plummeted to only 50 doctors. This occurred as a result of the exodus of 95% of the expatriate doctors. Prior to the Ebola outbreak, the nurses went on strike or slowed down work throughout the country due to work grievances. This was true in Lofa, Bong, Bomi, and Montserrat counties, which have been hit hardest by the epidemic. These nurses returned to work after negotiations with the Ministry of Health just before Ebola entered the country. After the outbreak began claiming the lives of the nurses who did not have protective gear, the nurses fled the hospitals. After a second Liberian doctor died of Ebola, all of the government hospitals shut down. The patients are too terrified to enter the buildings. The nurses have stated they will not return to work unless they're issued adequate protection, including gloves, gowns, and goggles. At the ELW hospital, in conjunction with Samaritan's Purse, doctors and nurses continue to treat Ebola patients. There are 5 doctors and 77 nurses and aides. This is the only place in Monrovia where treatment for Ebola takes place. Currently, there is only enough space for 25 patients in the isolation center. Initial attempts to expand the unit were met with protests from the local community, which did not want Ebola patients coming from all over Liberia into their community. Having allayed the fears of the community, Samaritan's Purse will complete an 80-bed unit in the next 2 weeks. The only other treatment center in Liberia is a 40-bed unit in Lofa County. The case fatality rates range from 80 to 90% at both facilities, owing in part to the delays in people seeking treatment. Many patients die within 24 hours of presentation. ELWA is the only functioning hospital in Montserrat County, a population of nearly 1 million people where Monrovia is located. Many patients are dying with Ebola in their communities, in part because there are simply no open health facilities. This creates problems because whole families are getting infected and dying. There is no way to count all the people dying of Ebola in the villages and in the remote areas. The cause of death is often unknown, and there exists a lot of suspicion toward Western and government health workers. As a result, information is often withheld from health workers. Advice on safe burial practices or abstaining from eating bats and monkeys is oftentimes met with resistance and even violence against health workers. To complicate matters further, usual illnesses such as malaria, typhoid, pneumonia, and surgical emergencies result in death, as there are no functioning facilities at this time. The death toll will undoubtedly reach into the tens of thousands in Liberia unless immediate actions are taken to 1, increase the capacity to treat patients in isolation, 2, create an effective means of quarantine for those suspected of having been exposed to Ebola, and 3, provide protective gear to all healthcare workers and those involved in disposing of the bodies of patients that have expired. Given the episodic nature of Ebola, we must begin investing in healthcare system strengthening as we prepare to deal with future outbreaks. SIM and SHIELD stand ready to assist in the building of capacity of West Africans by training and producing more African healthcare professionals. Thank you.
Thank you so very much, and for your lifelong commitment and for building up capacity and doing it yourself in working with others at SIM. Let me ask you just a few questions, because your testimonies, I think, were very comprehensive. You said, Mr. Isaac, that the international response, you deemed it a failure. And of course, no failure need be a failure in perpetuity. And I'm wondering if there has been a turn of the corner, again, inspired by the tragedy of 2 of your workers being affected by the Ebola virus? And secondly, could you tell us how they're doing? How are their spirits? Whether or not there's a sense, even if it's it's not fully backed by science yet, that the drug ZMapp may have had an impact. I think, you know, one of the questions I asked of the earlier panel, if some of these interventions prove to be efficacious, delay is denial if you have Ebola. And since this seems to be ramping up and not ramping down currently, your thoughts on an aggressive FDA working in cohort with, in conjunction with the other agencies of government to get, based on an opt-in, of certainly recognizing the risks, as Dr. Brantley certainly did, and Ms. Whitehall.
So on the failure aspect, I would say that I think the full international impact of Ebola has not been realized. I believe that Ebola threatens the stability of the 3 countries where it is affected right now. My staff met with the president of Liberia for almost 6 hours last Wednesday. They described to me that the atmosphere in the room was somber because she realized the full gravity of it. If you read the Ministry of Health status reports that come out every day from Liberia, I don't mean to be dramatic, but it has an atmosphere of apocalypse now in it. There are bodies lying in the street. It's on the front page of the Wall Street Journal. And today, there are gangs threatening to burn down hospitals. And this is essentially a society that is, let's say, a generation from everybody had post-traumatic stress disorder from a horrible war. They can go from a normal conversation to a fist fight to sticks in a flash of an eye. So they have a lot of temperament, and they have a lot of investment in what is going on. There's a lot of emotion. But it isn't just Liberia. It's Sierra Leone. It's all of these countries. What would happen, you know, I don't want to, I mean, you can use your own imagination in Nigeria, Lagos. What could happen there? And I believe that this disease has the potential to be a national security risk for many nations. And I think it will have an impact even on our national security. It has been a failure because it's now jumped another country. Because the epidemiologists have totally misread the magnitude of the disease, and because there are not resources on the ground. The status of the 2 patients, you know, I can say that I hear from Emory the same thing everybody does. They seem to be getting a little better every day. I do not think this will be a fast process. After that medicine was administered, after it was brought to us by the NIH people, and Dr. Brantley was very much involved in giving his informed consent to it. He understood, as did Nancy Whitehall. There was improvement, and I think as the doctors were saying here, I'm not a doctor, you know, I don't want to guess at science, but I will say that they seem to have gotten better. They got home. They're in Emory. We appreciate Emory. They're getting good treatment there, and we just pray that they survive and can recover their health.
Let me ask you, you pointed out 4 different areas: kissing the corpse, community health workers, medical professionals, as 3 of those. Now, let me ask you about the community health workers. You pointed out that in one cluster of infected individuals, 8 out of 12 were community health workers. Now, doctors obviously have a higher degree of training. They understand the essential importance of protective garb, and community health workers might not have that same level of indoctrination about how important that is. In your view, are they much more at risk because they are more rudimentary in what they do, therefore they're not taking the precautions?
So In my view, yes, they are more at risk. It's not just to do with the personal protective gear, but it's also to do with the lack of education. If you look at the symptoms of the disease, fever, joint pain, vomiting, and diarrhea, I'm going to guess that probably covers 50% of all the diseases that present to them. That puts them in an untenable and weak position of being exposed to the disease and not exactly knowing what it is. I just am saying that I think that there needs to be focused education efforts on these 4 levels of society: general public awareness, community health workers, medical professionals, and national leaders. That each one need, like I don't think putting a poster up on the wall saying Ebola kills is going to do it. I think that there has to be a programmatic approach to each one of these stratas of society to get the essential information that they need to encourage people from their position and to deal with the things that come to them.
I have been advised, Doctor, please.
Yeah, I would take a slightly different take on it. I believe that community health workers, if properly trained, can get the same outcome of coverage as physicians. What we have to understand is that health workers don't get Ebola because of carelessness, necessarily, or because of lapses in sterile technique. In the case of these workers, for example, it's very likely that they contracted Ebola from other workers who were at the hospital who may have gotten the disease from the community. So if you're working alongside someone and they happen to have Ebola, then you get it from the staff. And so there are a number of documented cases of staff infecting staff. In fact, just yesterday's report in Cacata in Bone County, where 4 nurses died and 11 more were infected. And so there's a lot about the infectivity that we don't realize in terms of how it happens.
Let me just say, in terms of getting the message out in a way that will be most likely received so that people understand the catastrophic nature of the disease, my understanding is that Guinea today is recruiting retired doctors, nurses, and midwives, authority figures, older rather than younger, to convey this message. Have you heard that? And are the other countries, the other 2 countries, and perhaps even Nigeria too, looking to do that so that authority figures convey, again, the paramount importance of, for example, burial practices and the like?
Yeah, one of the challenges we have in Liberia is after this 14-year brutal civil war, during that period of time, people did not go to school. So you have a large population of illiterate people, and many of the languages in Liberia are not scripted. So you can't write something. So there needs to be language appropriate in each dialect in a way that each community can understand it so they can get the message. So it requires people that are seen as authority figures, but also people that are able to communicate in the person's spoken language so they're able to get the message. So as he says, putting a poster up is not going to help someone when you've got an illiteracy rate of 75%.
Finally, just let me ask Mr. Isaac, if you could. You said that the president of Liberia was a month late. Is it too late? And what would have happened had that state of emergency been declared a month ago?
The month statement was not a scientific statement. It's just an opinionated statement, and when I don't have knowledge, I always have opinions, rightly or wrongly. But I do think that Liberia would have been better served had a status of emergency been declared earlier. Now, I don't know all of the actual mechanisms that will go along with that declaration, but it is clear to me that Liberia is in a severe crisis that I believe threatens the stability of society as it exists today. And I think that as you see the disease spread in Freetown and in Conakry, hopefully it's peaked there, and in Monrovia, you're going to see more instability and insecurity.
Let me ask about the question of testing. And you heard the exchange earlier with Dr. Frieden and other members of the panel about the lack of labs, lack of testing capability. Even if you might want to comment on that, but even in the best of circumstances, say at in New York or New Jersey, how long does it take to get a test back? Because this does move very fast.
Well, they have special tests in the U.S. that are just a matter of a few hours. But logistically, when you look at the infrastructure of these countries, to go from one point to the other on the map, it may look like, oh, it's just 50 miles. That 50 miles could take you 8 hours because you can only drive 3 miles an hour through roads that are impassable. So a lot of logistical problems here. But I believe the #1 cause of healthcare worker infections in Liberia is the lack of the protective gear. They're asking people to go to work, to take care of patients, and they don't have gloves. And to me, this is unconscionable. So if we're going to put people on the line, the brightest and the best people in the country on the line, we owe it to them to give them a fighting chance. Even in this country, no matter how well-trained a doctor is, if an Ebola patient comes up to him before he or she knows what he has already been infected.
Mr. Isaac, you asked the question earlier, where will the money go? What will it buy? Where, in your opinion, should the money go, and what should it buy?
So I sort of feel that I think that international personnel are needed. I frankly do not think that the Ministry of Health of Liberia can fight this. They do not have the case investigation capacity. I talked with a senior person in CDC. I won't name her, but she's a well-known person. She told me that in the United States, if there was one person that had a level 4 infectious disease, they would have many hundreds of contacts to run down. There's no contacts being run down in Liberia. I don't believe that the Liberian government, as well-intentioned as they are, and I do believe that they're well-intentioned, I just simply do not think that they have the capacity. I am all for building the capacity, but I think there needs to be something to augment their capacity. I think that there needs to be some kind of a coordination unit. I have heard here today that the World Health Organization has the lead. Maybe, maybe not. I think that probably something with a bit more of an operational edge to it is called for. That may be some kind of a, you know, I don't know what that could be, but more is needed. And I think that if we leave this situation up to the ministries of health, I mean, you have a unique situation where you have 3 poor countries that have a communicable, infectious, and lethal disease that clearly don't have the capacity to contain it, and is the world willing to allow the public health of the world to be in their hands while they try to contain the disease? I think that's the essential question.
Thank you.
Yes.
And finally, Dr. Glover, you had worked on the DRC outbreak of Ebola, what, some 20 years ago?
Actually, I was, at that time, I was working in Zaire. It was in Zaire, in Kinshasa, but the outbreak was in Kikwit.
Okay.
So I was there during the outbreak, but I wasn't actually working with the Ebola.
How does this compare to that outbreak?
There is no comparison, because back then it was a very sparsely populated rural area where it could essentially burn itself out. But you have so many people in Liberia that have moved to the city so that they're living very close. If you look at a taxi cab or a bus, you wonder how could they get so many people jam-packed in there, or how many people live in a house, for example. So there was an instance at the Phoebe Hospital where the administrator came down with the virus, and he infected his 8 children and his wife, and all 10 of them died. So the close proximity that the people are living, the concentration of the population means that as this epidemic, no matter what we do, unfortunately, there's going to be tremendous loss of life just by the nature of this disease.
Well, I thank you both. If there's anything you'd like to add before we conclude the hearing?
I would just say that I think much more, I'm certain there's much more than I know of, but this concept of research and development for a vaccine and a cure is very important. I agree with Dr. Glover. I think we're going to see death tolls in numbers that we can't imagine right now. That is potential. And also I will tell you that we are now, as Samaritan's person, in the process of distributing Ebola readiness information to all missionary hospitals across Africa.
Dr. Glover? Any final words?
No final words.
Thank you. I want to thank both of you again for your extraordinary service to mankind, and especially to the sick and at risk and disabled and those who are suffering this terrible outbreak of Ebola. And we look forward, if you could, stay in touch with our subcommittee. This is the first of a series of hearings. We're looking to make sure that whatever we need to do as a Congress and as a subcommittee, and me personally and my colleagues, we want to do. And again, your guidance is absolutely essential. Thank you for sharing your wisdom and insights and incisive commentary to the committee. The hearing is adjourned.
Thank you.
Okay, thank you. Nice to meet you. Huh? Nice to meet you.
Nice to meet you. Where do you live?
I live in Albany, Georgia.
Okay.
A few hours from here.
Yeah, I live in Boone, North Carolina.